All right, welcome back everyone. So here we're going to pick up and we're going to begin talking about something called cardiac output. So we've mentioned previously something called stroke volume. And if you recall, stroke volume was simply the volume of blood, the amount of blood that leaves the heart during a single contraction, right? So how much blood leaves the ventricle during one contraction. Um, what you can do is you can take that value, so the stroke volume, typically expressed in milliliters, right? So milliliters per contraction, and multiply that times your heart rate, so beats per minute, and what you end up with is the amount of blood that leaves the heart in a single minute, right? And so this is referred to as cardiac output. So it's a function of heart rate and stroke volume, right? And so if you influence one of those, or if you alter one of those, so whether it be stroke volume, whether it be heart rate, as you change one of those, if you keep the other one constant, then you're going to have a change in cardiac output, right? So if you have a stroke volume of 60 milliliters, and you have a heart rate of 100, right? All you're doing is you're taking 60 and you're multiplying that times 100, so that's 6,000, right? So that's 6 liters per minute, right? So 6,000 milliliters per minute. That's the amount of blood that is being pumped out of the heart via ventricle during a single minute, right? And so we'll talk about some factors in this video, this part and the next, that affect heart rate, and then we'll look at factors that affect stroke volume, right? So we have our heart has a pretty good ability at maintaining cardiac output to meet our tissue's needs. And again, the specific amount, so the specific cardiac output, that number per minute, milliliters or liters per minute, that's obviously going to vary slightly between individuals. So again, women versus children, people who are larger versus people who are smaller, right? There's variables that can affect both stroke volume and affect heart rate as well. Other factors have to do with the strength of the heart, right? So the second point here is individuals with stronger hearts have larger stroke volume and a slower heart rate, right? So if you have an increase in one and a proportional decrease in the other, then your actual cardiac output is going to stay about the same, right? So this is things like endurance athletes, right? So the resting heart rate for endurance athletes can be extremely low. So the heart rate is lower, but the efficiency of the heart, if you will, is still very efficient, right? So it operates to a high level. So in other words, the stroke volume itself is greater even with a lower heart rate, right? So again, the cardiac output is going to be about the same, right? Now, our heart, and we'll talk about reasons why this is in a moment, but our heart has the ability to essentially accommodate different kind of physiological states we happen to be in. So meaning whether we are exercising, we are playing a sport, we're running, we're doing something where maybe we have an increase in kind of metabolic demand in terms of the need for oxygen for tissues. Our heart has a good ability to compensate for that and pump out adequate amounts of blood for our tissues needs, right? So cardiac output, again, this last point down here, cardiac output can increase fourfold in healthy non-athlete type of individual and up to sevenfold in athletes, so those with a significant endurance level, right? A significant aerobic endurance. So in other words, our heart and our body has the capability of meeting the demands of our tissues depending on the state that we happen to be in, right? Now, our heart rate specifically. So again, heart rate is just one part of cardiac output, right? So if you want to change cardiac output, if you want to alter cardiac output, you have to change either the heart rate or stroke volume, or in some cases both, right? So one way you can change the heart rate is simply by increasing it, or you can decrease it, right? So any type of molecule, drug, medication, hormone that changes the heart rate, that's called a chronotropic agent. That prefix chrono is referring to the heart rate, right? The rate of the heart, how fast is it beating? And so if you think about what is setting our heart rate, right, you can think it's our conduction system, right? So it's our SA node. It's that pacemaker potential we've talked about in previous lectures, right? So if you can alter the SA node, and I'll show you an image here in a moment of what that would look like. But if you alter the activity in the SA or the AV node, then of course you're going to influence the rate at which you have these stimuli leaving the pacemaker, which is going to influence your heart rate, right? So if you increase your heart rate, or you have a drug, medication, hormone that increases your heart rate, that's called a positive chronotropic agent, right? So something that increases heart rate. And again, we'll look at how that is in a moment. I'll show you a graph. But think of this as something like epinephrine or norepinephrine, right? On the heart, right? It acts on beta receptors, and we'll talk about in a moment exactly how that works. Okay. So here you see a neuron. So this image, this structure right here, this is a neuron. Here's our SA nodal cell. So again, in our SA node, so one of our pacemaker cells, right? And so various hormones, various molecules, and we'll talk about some examples in a moment. All of those, what they're resulting in is they're resulting in that pacemaker potential. You result in reaching threshold sooner, right? So in other words, it takes less time for that pacemaker potential to occur. So you get a faster, more frequent stimulation of the heart, which results in a faster heart rate, right? So some examples: thyroid hormone, caffeine, nicotine, cocaine as well. All of these are positive chronotropic agents, right? They're increasing the rate at which you can reach threshold, right? If you do the exact opposite, you simply call that a negative chronotropic agent, right? A negative chronotropic agent. And so this is something that's slowing the heart rate down. So acetylcholine's effect on the heart. Maybe you have the vagus nerve, right? The vagus nerve is a negative, or it has a negative chronotropic effect on the heart. So think parasympathetic activity, right? So in this case, the rate at which you have your pacemaker potentials is less frequent, right? It takes longer for you to reach threshold, so your heart rate slows down, right? Beta blocker medications are another good example of something that has a negative chronotropic effect, right? So these are medications that are given for patients who have maybe high blood pressure. They have a high heart rate, maybe associated with high blood pressure, and this helps to bring that blood pressure down by causing the heart rate to decrease. So again, decreased heart rate, stroke volume, cardiac output is typically going to go down. These drugs end in OLOL, O-L-O-L, so things like metoprolol, propranolol, labetalol. All of these are beta blocker drugs, right? So these are drugs that bind to and block the beta receptors, those beta-2 adrenergic receptors on the heart, which results in decreased heart stimulation, right? So slowing the heart rate down. Now, something with beta blockers, if you recall from endocrine discussions, there's a process called upregulation and downregulation, right? So upregulation was the idea that you express more of a receptor in response to inadequate levels or concentrations of a hormone, right? So in this case, for beta blockers, you would have upregulation of beta receptors because those receptors are being blocked and they're not binding with epinephrine. So the body tries to compensate for the lack of epinephrine and norepinephrine binding to the receptors by producing more receptors, right? So this is normal. This becomes an issue when a patient suddenly decides to stop taking their beta blocker, right? So now you stop taking your beta blocker. You now have all of these receptors due to this upregulation of the beta receptors, and now you still have the epinephrine, norepinephrine, and so you can get something called rebound hypertension. So in other words, the hypertension rebounds, it comes back, and it may even be more severe than it was originally, because now you have more of these receptors to bind more epinephrine and results in a higher blood pressure, right? So this graphic here, what this is showing the change in the pacemaker potential. So again, this graph is showing pacemaker potential. It's showing a change in the rate or the frequency of the pacemaker potential in response to something that is positive chronotropic or negative chronotropic, right? So this black line in the middle, this is normal, okay? So you reach threshold here after a certain period of time. This red line here, would this be, so this red one here, would this be the effect of a positive chronotropic or a negative chronotropic? So hopefully you're thinking this would be the result of a positive chronotropic, right? So in other words, you're reaching threshold faster, right? Faster than what you have in this normal graph here. So what this means is that you get the pacemaker potential more frequently. So you have the SA node firing at a faster rate, which thus leads to a faster heart rate, right? So positive chronotropic. This green one, and again, this would be something like epinephrine maybe. This green one, vagal, this is parasympathetic effect. This is negative chronotropic, right? So again, beta blocker, something like that, right? Acetylcholine's effect on the heart, right? So now you've taken the amount of time it takes for this cell to reach threshold and you've stretched it out, right? So now you have these pacemaker potentials less frequently, and so that's going to cause the heart rate to decrease, right? So last thing we'll mention here related to heart rate before we pause and then come back and look at stroke volume are things called autonomic reflexes, right? And so these are autonomic, so again, think automatic reflexes that then influence the autonomic input on the heart, right? So sympathetic and parasympathetic activity. And one of these is called the atrial reflex or the Bainbridge reflex, right? So this protects our heart from overfilling as the atria stretch. So as blood is coming back into the atria and the atria begins to stretch, what this does is there is a signal detected by what are called baroreceptors. Baroreceptors are receptors that detect pressure. So that prefix baro is referring to pressure, like a barometer measures atmospheric pressure, right? So there's these baroreceptors that detect this stretching, again, due to the amount of blood coming back to the heart, sends a signal to our brainstem in a region called the cardioacceleratory center. It's a part of our medulla, all right? And this then sends a resultant, so that's the sensory part, right? Then that sends a motor signal out to excite the heart. So again, cardioacceleratory, increased excitation of sympathetic axons to the heart, resulting in an increase in heart rate to then compensate for that increased venous return, right? So in other words, your heart is going to begin contracting more quickly as a result or in response to the increased venous return, right? So again, to help move and eject that blood out of the heart, resulting in less atrial stretch. All right, so we're going to stop there, and we'll pick up in the next part, continuing to talk about the other half of cardiac output, which is stroke volume.